10 o'clock, and we'll call the Grey Bruce Public Health meeting to order. I'd like to welcome everyone. And first of all, we'll start with the roll call, Kaylee.
Good morning, everyone. Sue Carlton,
Present.
Sue Patterson,
Present.
Larsa,
Present.
Luke Charbonneau,
Here.
Kristen Diwali,
Present.
Claire Singling,
Good morning, everyone. Did you hear me, Kaylee?
Dick,
Thank you.
Kevin,
Was that me?
that's you.
Okay. Present.
Thank you. Brian Milne. Nick Saunders. We have four.
Okay, thanks, Kaylee. Any amendments to the agenda from anyone? Mr. Craig?
Thank you, Mr. Chair. On the minutes from last meeting, there was the acknowledgement of the journey of COVID, and it was recommended that the COVID-19 update be taken off as a standing issue. So I'm wondering if 7.1 is that standing issue or whether there is actually new information that is to be presented.
Barrett?
Mr. Chair, we decided if we have 3 negative meetings, we will take it off the agenda. So this would be the third one. This is the third update.
Okay.
Dr., you had an amendment?
Mr. Chair, since the agenda went out, we had the board training, and that was on May 24th. And so there will be added minutes to the agenda if possible.
Okay. Anyone else for any amendments to the agenda? Okay, seeing nothing, then we move to the approval of the agenda. If someone move and approve the agenda. By Sue Patterson, seconder, and Craig. Further discussion on that? All in favor? That's carried. Any disclosure of pecuniary interest for anyone? Seeing none. The adoption of the minutes from Friday, April the 28th. I have a mover for those, please. Moved by Helen Claire, seconder by Luke Charbonneau. Any further discussion on those minutes? Obviously, there was revised ones that went out yesterday or the day before, the better times what the originals were. Seeing nothing, then we'll call the vote. All in favor? That's carried. Correspondence and news releases. That's on camera. Correspondence and news releases, Dr. Do you want to do this or does it need?
Certainly, Mr. Chair. So we have a list of correspondence. So there is 5 items on the correspondence list. One is letter from the Board of Health for Peterborough to the MP to the Prime Minister, Justin Trudeau. The letter from the Chair of the Board of Peterborough requesting the federal government to support Bill S-254 to improve the health awareness, individual health decision-making around the consumption of alcohol through warning label on alcohol beverages. So more or less using warning labels similar to the warning labels that we use on tobacco or other items. And my recommendation is to receive. The second item is a letter from the Chatham Kent Board of Health to the Premier of Ontario. And the letter is urging the Ontario government to adopt income-based policy solution to reduce household food insecurity. And income-based policies such as providing basic income guaranteed, increased minimum wage, indexing social assistance, and the recommendation is to receive. Number 3 is a letter from the Board of Health for Temiskaming Health Unit, and it is echoing the same messaging from Chatham-Kent related to food insecurity and solutions for the situation. And again, the recommendation is to receive. The number 4 is a letter from the Board of Health, Chatham-Kent, and it is urging the provincial government to provide universal and free coverage for all prescription contraception options to all people living in Ontario. A few years ago, there was the introduction of OHIP Plus that would cover contraception for people under 25 years old. And the recommendation in this letter is to urge the government to cover everybody. And the recommendation is to receive. And the final one is a letter from the Board of Health for Peterborough. And it is echoing the correspondence from Chatham-Kent regarding the universal coverage or no-cost coverage for prescription contraception. And the recommendation is to receive. My apologies. I see that it's endorsed on this item.
Okay. Questions, comments? Okay,
Through you, Chair, to Dr. Era, is there the expectation, besides all the health benefits of the expanded contraceptive policy, is there the expectation that it will lessen or decrease the number of terminated pregnancies? Like, is that an expected outcome, or is that a planned outcome of this policy, or is it all about women and girls' health? Does he understand what I'm?
Yes, through you, Mr. Chair. It is to be an expected outcome of this, but the major drive here is to ensure that people have options and are able to plan their future. Some people are covered through insurance from work or through insurance from different agencies, and having this option to everybody is it's a benefit for the society at large, not specifically for prevention of early termination of pregnancy or abortion.
Okay.
question, and just, I guess, for clarification, what the difference in between prescription would be. So this is prescription then you would get it from the doctor?
Correct.
Okay, not, I was just thinking, all stores sell products like this, so this would, okay, the difference is then you would go to your doctor and get a prescription for this. Okay. Other questions or comments? Carl.
Through you, Mr. Chair, to Dr. Era. The first letter regarding the warning labels on alcoholic beverages. So I read that letter as being more that they didn't label all alcohol bottles, that only some. So it read to me as if there were 3 choices of vodka. Somebody would walk in and say 2 of them have got a label, I'll pick the one that doesn't. So there was a decrease in the number that were labeled. So to me, it would only be really pertinent if all were labeled, and then you could tell whether there was a decrease in purchasing. But maybe I'm just misreading that letter.
Sorry, can you elaborate a bit more on that?
Well,
question?
let me just find that one here. So what it says is, a recent pilot study in Yukon introduced alcohol labels and saw a decrease in sales for labeled products by 6.6%. So it doesn't say if all products were labeled or they just saw a decrease in the ones that were labeled. I think that would be.
I see your point. Through you, Mr. Chair. So like in general, the function of label is to provide information to the consumer so people can make an informed decision. And from the experience with different products, specifically the tobacco, when people know that the item has potential for carcinogen, or later with the label, there are certain pictures actually showing a carcinogen effect or cancer, you would see in general, decline in the use of the substance when people know the effect or the content of
The first one.
the consumed substance. So having universal approach to label these products and put the appropriate amount of content, whether it's alcohol or other substance in the product, is again the for the benefit of the entire society at the end of the day. Does that answer that?
I think so. I think it just, the way I read that is that they hadn't actually labeled all products, just some, so people just didn't buy the ones with a label on it.
Right.
Okay, thank you.
Okay, need a mover then to receive those 5 pieces of correspondence. Moved by Sue Carlton, seconded by Ken Craig. Any further discussion then on receiving that correspondence? Seeing nothing, all voted all in favor, that's carried. Next is media releases.
That should be
Thank you, Mr. Chair, and through you, we only have, we only have one media release on today's agenda package. On May 12th, Public Health issued a release that sought the public's help in identifying the owner of a dog that was involved in a biting incident in Southampton on May 10th. Graybers Public Health was looking to confirm the dog was not infectious with rabies, and by verifying the health of the dog, the victim can avoid receiving the post-exposure rabies treatment. And that's the only media release for this meeting.
Okay, thanks, Denis. Any questions on that one? Could I have a mover then to receive the media releases?
Could I just ask a question, Mr. Chair?
Sure, Luke, go ahead.
I just wondered, just very quickly, maybe to Dr. Era, how successful are these releases? How successful do they tend to be? Do you tend to find the dog in question when you put out a release like this? Did this one work?
It has been very helpful in certain occasions, and it was futile in others. It really depends on the type of incident. Sometimes the animal is identified or known or domestic, and other times it's not. And it could be a visitor or it could be local. So in general, it's the best practice to put them out, and we definitely have good benefit from some of them.
Are you prepared to move the media releases, Luke? Sure, okay. So need a seconder. Mr. Eccles, you still on there? Okay, Alan Clare.
Yes, I am. Yes,
All
I
right,
am.
Okay, sorry to wake you up.
No, it's quite appreciative. I thank you for that, sir.
Okay, all right, no problem. Okay, we have a mover and second, we'll call the vote in all in favor, that's carried. Done with media releases. Now we are on to medical officer health update, 7.1, the COVID update, sir.
Thank you, Mr. Chair. So on the COVID front, this is the 3rd month in a row that we have a very stable and low number of cases and outbreaks. And I would see that the management of COVID will become similar to the management of any other infectious disease going forward. We might have surges, but we have the capacity, and the public and the system, healthcare system in general, is quite equipped to handle any surges. So my recommendation is to remove this item going forward. So that's the update on COVID. And related to it, and there was a request from the board in the last meeting to have a discussion about the safety of vaccines in general in Canada. So I will share my slides to cover the subject in a few items as a presentation. Okay. Be up very soon. People can't see the presentation,
We can see it, I can see it.
but it's not up on the screen here.
Oh, because,
I can share it from the screen locally, yeah.
I think it's the clip share. There,
Just if you can double check if they can see it as well.
they
Okay.
can,
So,
It's good.
again, the vaccine safety in Canada in general, there are multiple layers of controls to ensure any product related to a vaccine or vaccine-related products are safe and effective. And this happens before licensing of vaccine and post-marketing. And this is not by any means exclusive of the whole list, but it would give you a very reassuring picture, I trust. So Health Canada Biological and Genetic Therapy Directorate is one of the bodies that regulates biological drugs, including vaccines, and they have their reviews of submissions. New drug submissions contain extensive data about vaccine safety, and that's from preclinical trials, from clinical studies, and this is all before a vaccine is licensed. Details about production information, therapeutic claims, side effects. Quality evaluation include on-site and lab testing of samples from 3 to 5 consecutive lots, and there should be consistency and reliability among all these lots, and that's happened through the directorate itself, through the industry. There is a set of guidelines, good manufacturing practices required for selling vaccines in Canada, and you can see that there is quite the rigor in it. All vaccine producers, manufacturers have to adhere to these guidelines. They must adhere. The use starting material that are characterized with defined origin of accepted quality. So whatever they're going to use in the vaccine, the origin of that substance, where it was manufactured, the quality of it should be reviewed. This all be done in licensed establishment and validated by demonstrating specification are met in at least 3 times in a row. And that's consistent with the trial or clinical trial that was submitted by the manufacturer. So they always compare the lots that are produced or the substance that are produced with what was submitted before. And that redundancy is necessary. It's consistent with each new lot having the same characteristics lot. That's what I was mentioning pre-authorization. So after authorization and marketing, that's where actually the absolute trigger comes, because in clinical trials you have 200, 300 patients, or 1,000 or few thousand. When you market it, you have millions, and in the case, for example, of COVID, you have billions. It has been distributed across the world, multiple doses, so there's huge sample to look at. And the vaccine lots released program, that's one of the quality monitoring activities. So the coming 4 slides or 5 slides to the end of the presentation are examples of these quality monitoring activity. Vaccine lot release program, and you can see there each vaccine lot produced is subject to a lot release testing by the manufacturer and independent laboratories. So you have the manufacturer who does the testing, then they hire a third party to look at it, and after that you would have Health Canada and other agencies perform the same testing and cross-examination of all these information. And again, it's all consistent with the GMPs, the guidelines for manufacturing. Other programs are the Canada Vigilant Program, safety reports, risk management plans. Each one of them is a slightly different approach or different organization, but all of them are connected at the end of the day to cross-examine the information they have. This is a very robust surveillance system, the Canadian Adverse Event Following Immunization. And, if you look at the definition of what is an adverse event following immunization, it's anything and everything, whether it's redness on the skin to motor vehicle accident, because that person was driving the motor vehicle accident. If they had a vaccine a couple of days before or a few weeks before, they could have fainted because of that vaccine and end up in the situation they are. So nothing is excluded. You include more and you look at patterns, and the coming slides would show how patterns surface, whether the incidence was reported multiple times in different settings. And includes spontaneous, enhanced, and active reporting. And so the spontaneous could be from the public. The public can go and report, I had this vaccine and I had this incident. Whether it is related to the vaccine or not, the system does not exclude it, rather include it. And it could be excluded later in trends, but that's what a good surveillance system does. Nothing is off the table, everything's included. The athletes reporting is legislated requirement in several provinces and territories. Healthcare providers and manufacturers must report any adverse events, and the reporting comes as so. The local level, the provincial level, then the federal level. So these reports would come to the health unit from every physician in the area, from every hospital, and we collate them and we send them to the province, to the provincial level. Obviously, if there are trends that we see locally, we will identify them, but usually vaccines, we're talking about adverse events of if it's severe adverse event, we're talking about 1 in 100,000 or more. So in Grey Bruce, you might have one incident or two, so there isn't a chance for a trend. But when you send it to the provincial level, there will be more ability to identify signals. And from the provincial level, within 15 days, the data will be sent to PHAC, a Public Health Agency of Canada. It's a branch of the federal level monitoring, and it will be sent de-identified, so there are no names. But the signals would absolutely be very clear at the national level. And PHAC will inform Health Canada and NACI. NACI is a National Advisory Committee for Immunization. More monitoring happens, immunization monitoring program active. It's called IMPACT. It's National Surveillance Network, 12 pediatric hospitals, tertiary care, large hospitals, and their ability to identify any adverse events after immunization. So again, they connect to that bigger system. Vaccine Vigilance Working Group is another federal and provincial level. And obviously, we have collaboration with other international agencies, whether it's CDC, World Health Organization, and any trends or signals that are found somewhere else will be tested. And this is, excluding any investigation that happens based on the surveillance. So there are many layers of redundancy to ensure that if a vaccine is given, it is safe, and monitoring it continues to ensure it is safe. Otherwise, we will be informed, and changes need to be made if it's need to be made. But I have zero concern about the safety of vaccines in Canada. This is one of the things that are very robust. Open to questions as always, Mr. Chair.
Excellent. We'll take questions. Okay.
Through you, Chair. Thanks for that. Appreciate the update. If I go home and check out these acronyms, is this all public information online?
All of it is public information.
Thank you.
Okay, any other questions? I don't see.
Dr. Aaron just had to change your screen.
We'll get
Yeah,
back
I was trying to go back to
okay.
stop sharing. There we go.
Helen Claire.
Thank you, Mr. Chair. Through you to Dr. Ara, wondering, it's great news that COVID is no longer such a threat in our community. Wondering if Dr. Ara could speak to long COVID. It seems to be still a relatively new concept where we're aware that there's something potentially as a result of COVID, but there's lots of those symptoms that also could be part of other things, is my understanding. So really determining what is long COVID and its treatment, I understand to be not really something that we have a handle on. So I wonder if you could speak to that in the global sense. in terms of long COVID and what it is and our understanding, and also in our specific local sense, do we have a sense of how long COVID is affecting our community? Thank you.
Through you, Mr. Chair, thank you for the great question. So again, the risk of COVID wouldn't change overnight. My announcement that there are 3 consecutive months where the numbers are very low, it's for the practicality of our agenda and meeting and updates. Obviously, the circulation will continue to happen. Related to the long-term COVID, the COVID remains a novel disease in a way that it has been 2 or 3 years, and long-term COVID is being studied specifically on the local level. We can't interact with it as much. Like you rightly said, it's related to the healthcare system, and the numbers in Grey Bruce, 170,000. How many long-term, and is it confirmed or not confirmed, with the notion that it's a disease that's being studied only for 3 years? There are individual claims. People would say, I have long COVID, but when you need to make public health decisions and interventions, they need to be based on the solid data from provincial, national level. And at this point, I'll turn it to Dr. Zayed. I'm not aware of many changes in our practice to address long-term COVID, other than referring them to the healthcare system, where they will be verified and helped, regardless whether it is COVID related or not.
Through you, Mr. Chair, I just want to, I agree with your comment, Dr. Era. In addition to that, there are some, not speculations, there are risk factors that cause chronicity for COVID, and this is ongoing, studied right now in clinical practice in Canada and all over the world, in terms of treatment, in terms of highlighting this risk factor from the beginning. But usually the risk factors are related to post-inflammatory, like people who have certain inflammatory diseases, like uncontrolled diabetes, rheumatoid arthritis, and other diseases in children, for example, Kawasaki syndrome. So there is no specific predictors for who is going to have long-term or chronic symptoms, but there are now more trials related to treatment, and whether people who receive treatment in the beginning, that will cut or shorten the time. But definitely there are cases of post-inflammatory, and there are now there is like a chronic disease surveillance in terms of that in Canada and across the world.
Thank you. Ben?
Through you, Chair. So when my neighbor shows up and says, I've got long COVID, whether they do or whether they don't, is long COVID a term that if you go to the doctor and says, I've got long COVID, the doctor looks it up in the book and says, oh yeah, that's what that is? Is that a clearly defined disease, or is that, as Dr. Zayed has said, is it the effects of something else that you've had that's been exacerbated by the effects of COVID? You can't say to somebody, no, you don't have it. That's a bad thing to do. But for my own clarity, is long COVID really a disease, or is it complications of many things?
Through you, Mr. Chair, it happens before with Lyme disease in 2014, when everyone was going to the States to take parenteral treatment for the post-Lyme disease. Again, this term is not scientific. So not everyone has some inflammation would be because of a tick they had. So again, the putting things in its context is important. So if a person have long symptoms or chronic symptoms after COVID, it could be related to COVID or not. So this is a decision by the clinician to decide based on inflammatory markers. that can actually detect and identify whether this is due to COVID or not. But again, I'm seeing that would be, again, something popular about everyone would have anything, would say long COVID, but this is not, this has to be, again, identified or assessed by the clinician. And it can be assessed for sure.
So, Mr. Chair, I echo Dr. Zaid exactly. To be more specific about the question, there is a term called long-term COVID, but it includes a spectrum of symptoms that are lingering and it is under investigation. So it's not one thing, and it could be multiple things. It could be related to other diseases. It could be standalone, but at this point, it's a spectrum that is used in mainly academic studies that is looking at these individuals who are suffering from the consequences after COVID. And Lyme disease is a very good example where it's so easy for people to say, this explains everything I've been experiencing. But, you know, is it? We cannot confirm, you cannot confirm unless you rule out all other options. And this is usually not straightforward public health function.
Okay. Any other questions then on the vaccine presentation? Okay, we move on to the opioid situation. Graham Bruce, I assume Dr. Dick will take this.
I just have a few updates on the preventive side for the LDCP, the locally driven community project that we have for prevention of opioid and illicit drug use among youth from 15 to 24. We are really progressing very nicely in this project. So we have the two components, a literature view about what is there for intervention and what we are actually doing as health units in the province. So we finished the literature review, and it's really great that we have done this review. It's suffering, but to go through 1,400 articles and then decide to read all of them and decide what is important. But it was really, it gives us some kind of highlights about how mental health is important. Like most interesting things that I have found is about internalizing, externalizing mental health symptoms, the cultural adaptation and the tailoring, the theoretical base for evaluation and implementation, the school-based program, intersectional framework, empiric intervention versus equity-based, how to evaluate a program for prevention, community coalitions, and it's good to see also the downsides of any intervention, so that when we have a recommendation at the end, we can really take this drawbacks in any program and make sure that is competent. There is some clinical and special situation, like for example, prescribing opioid for after surgery to children, what that imply, and in the context of a family who have opioid use. So is that trigger opioid use in youth? There is also strengthened family programs. So a lot of things on the upstream level, and hopefully we will have a report or recommendation by the end of June. That's for the LDCP. At the national level, they are very interested in the prevention effort of our prevention efforts. The Center of Health and Wellbeing in Public Health Agency of Canada connected with us. I had a meeting with them yesterday, and it's really great to see that at the national level, there is more interest now with the prevention for the next 5 years, and they are interested in the result that we will have from our study. The other things, I also received an invitation from the Embassy of Iceland through the Icelandic model. So the president of Iceland, so Icelandic model is coming to us when we were talking about that. So there will be a roundtable discussion facilitated by Dr. Teresa Tan on May 29 around the planitude and about the use of Icelandic model in Canada or at a local context. Because this model is used in Europe, but there are other countries have adopted that model. So it will be an interesting discussion or roundtable discussion that I will attend. In terms of harm reduction and treatment, we are continuously evolving in the outreach services with SOS, supported outreach services. There is a more work on the drug and alcohol strategy, leadership and steering committee. I joined the steering committee, so I hope that this will have this public health aspect, and we can have more work related to people with living experience as a most important thing, and the evaluation aspect of the work. So what we are doing in any pillar and how that is evaluated. So that's a great collaboration as well. In terms of surveillance, we are now back to baseline. So this cluster of cases and overexposure or toxicity clusters is over, but we are really working on in many intervention to try to keep that at bay and reduce or prevent or eliminate mortality. We finished a project charter study for SOS, and this will help the maintenance and sustainability of that project in terms of evaluation, what is needed. So continuous monitoring and tracking and having a dashboard for evaluation and surveillance of that work. In addition to that, I want to share my screen just to show you 3 slides about recent data that we have. We can see. Yeah, it's not really. It's very small, right? No, I think it's. So this anyway, this slide is one of the slides that we asked the chief coroner office to provide us with toxicology report. So this is a toxicology report from 2019 to end of 2022. This is divided by the toxicant or contamination or the cause of cause of death. What are the toxic substance? So as you see, I know that it is small, but this one has been the fentanyl. This is the most fentanyl component of the main one. It constitutes around 20% or more around this data. The other, sorry, Kevin, he has a question. Kevin has a question.
Kevin, sorry, go ahead.
Yeah, thank you. Just on that scale and whatnot, it's very interesting that methadone is used as a withdrawal drug or something like that. And here it is on the toxicology report as looks like it's had the opposite effect or the ending effect on at least a couple of, or at least one or two people at least were had died because of methadone, and we have clinics that's giving that out. Just clarify that for me, or what
Yeah,
seems
sure.
to be going on?
Through you, Mr. Chair, this is what they found in post-mortem. So it doesn't, like, this is maybe the material or the chemical that stayed in the blood, but there might be other things. So it doesn't mean that this is the cause of death, but this is a chemical they found in a post-mortem. But it's not a cause of death, like it's more the fentanyl and the other things. So this report is just giving us some information, but it is not the most accurate information.
Hey, Dr. Era wants to add a comment.
Yes, certainly.
Okay.
It's just want to clarify, it's not two individuals, 2% of the people who
2%.
died. So way more than two individuals. It could be part of the report. It's worth mentioning, any substance could be a poison. The definition of a poison is in a dose. Even if we drink water in a big dose, it could be fatal. So again, most likely in this case, and we can verify it if you wish, whether methadone, not if you wish, we will verify it. It's a good point to look at. Methadone was listed as one drug among other drugs that cause deaths, or it was standalone overdose of methadone. Again, anything can be lethal depending on the dose.
Yeah, so you, Mr. Chair, I agree with that. It can be an overdose of methadone. I don't believe that methadone in the usual dose would be a killing or a cause of death. But anything that they find in the autopsy, they report it. So it could be an overdose of methadone.
Yeah.
And
Okay.
Dr. Era?
Thank you. Yeah, that's clear.
yeah.
The next.
Dr. Era?
Sorry, I was going to say, alcohol is not on the list because it's not a legal drug, but can very well be the cause of many deaths.
Yeah, but this is an opioid and related
Right.
report. The toxicology report by quarter, this is another way. So this is very, I just wanted to show you that report as well. And this is an interactive, like I can show that is an interactive map. But if I click on any point here in the quarter, in every quarter, I can know the number of cases, and it will appear like a list of toxicants or substances by number. The other interesting slide is here is about the suspect drug-related deaths. The yearly breakdown from coroner with 2 weeks delay is about the dwelling or the living arrangements. So you can see here, private dwelling is 33. Total, like 22 in 2022, it was 24. Of course, we are still in 2023 is 9, but a large number, if we see, for example, the 2022, there is a large number of people who are in private dwelling. So we shouldn't really be saying only homeless. This is this is a social and complex problem. Homelessness is part of it, but we can't also ignore that people in private dwellings are dying from opioids. So that's an interesting part, and this correlates also with the same as Ontario. Like this is an Ontario comparison compared to Grey Coast. But our local context, I mean, this is an important part. That's why we have asked to have extend naloxone in many based on the increased consumption sites. We have now an interactive heat map or where the consumption, increased consumption and overexposure happen. And we provide naloxone to save lives in these areas. So it's not only about shelter, homelessness, and of course, this is part of it. But again, this part that shows private dwelling is alarming. That's it for me. I don't know how to stop sharing.
Any questions for Dr. Zayed on the opioid update?
I will just move.
Helen Blair?
Thank you. Through you, Mr. Chair. I'm aware that First Nations are outside of public health's responsibility, but of course they are our close neighbors, and they've been our closest First Nations. I'm aware that public health does engage as good neighbors, and I would appreciate hearing what that engagement has looked like over the last little bit, and for a status update on the situation on the First Nations as best as we understand it. And if I may, Mr. Chair, on a somewhat separate note, to do with the stats that we've just seen, a distinction was made between alcohol, that we're not collecting stats on alcohol because it's legal. I would respectfully point out that many of the drugs that were on that chart also are administered legally by prescription, and they find their way onto the street. And there's a great deal of coverage right now in the media suggesting that some of the drugs that are being given to control cravings are being then resold. So I just think it's very important for anyone listening that we don't make a false assumption that everything that we just saw on that data is related to illegal drugs in its source. Thank you, Mr. Chair.
Thanks, Helen Blair.
Through
Dr. Zayed?
you, Mr. Chair, there is multiple components of the question. So I will start first with Indigenous population. We are engaging efficiently and strongly with the communities, Indigenous communities, through being part of their task force for emergency task force. We are an active member in that. We have agreement. We signed agreement with Niyashiming and Sogin First Nation for the legal shared program, and it is we are actively administering that program in their area. And in addition to that, we did multiple naloxone teaching in both communities. The number of deaths or overexposure that happened also in Indigenous communities are included in our statistics. So any conditions that happen in both communities on reserve, we are aware about it through EMS, through the police, and through other first responders. In addition to that, the SOS team is now having mobile units or mobile outreach to both communities. It started to be very well engaged with Sogin, and now since around 3 months we have one in Yashiming, and we got approval for extension of funding for that one. There was no response from the community to work with that mobile team, but with time it started to gain trust, and involving indigenous staff in that work was very helpful. In addition to indigenous off reserve, we are actively involving with them as well in terms of all the equity, social determinants of health situations, and also actively involved with the indigenous lens of communication and addressing addressing the situation. The other part of the question is about the alcohol. We have data from CCHA about alcohol, and yes, we have actually higher number than Ontario. We have now a working group on alcohol, as this is through the drug and alcohol strategy. So one working group is working only on alcohol, and there are active work with that group, also at a community level, in addition to public health. And this is a really, and I agree, it's an important problem, especially when mixing drugs with alcohol. Like when we talk about, for example, this methadone as a cause of death, this can be perpetuated by taking alcohol with it. So like alcohol is really an important issue, even at a normal level, like not an addiction level. So we are really, this is in our plan since we recovered in a way. So we were trying to focus also on the alcohol with the new concept of the new guidelines. So this is also happening this year. I don't know if I missed any part of the questions.
That answer your question, Helen Claire? Other questions for Dr. Zayed? Ken?
Through you, Chair, just for clarity, Dr. Zayed, we're dealing with the opioid crisis. How broad does opioid expand as far as including illegal substances? Like you don't hear about the cocaine, you don't hear about crystal meth, you don't hear about heroin. Is opioid a family unto itself, or does it just encapsulate everything that we used to deal and the new fentanyls and the new all sorts of things? Can you just clarify that for me? Because if cocaine is still an issue, or have we forgotten about it, or what's the public health unit's strategy in that regard?
So you, Mr. Chair, again with the pharmacology report or a drug toxicity report, it shows cocaine and shows other substance. So when we talk about opioid, we mean opioid and other illicit drug use. So illicit part of the picture, they are both under the same risk factors and of course protective factors, but we are dealing with drugs in general under opioid and illicit drug use. And to the point also of Helen Claire about prescription, we are looking for or monitoring the prescription as well. We are dealing with this, we call it opioid stewardship. So whatever when we find, for example, oxycodone as part of the problem, we have to deal with that to see like an investigation to see if it is a prescription or non-prescription. And if it is a prescription, we have to go back to the physician and or the provider and see the circumstances of that situation. So we are dealing with that as well. But it is not as huge as the illicit drug use, but we are dealing with a prescription as well. And as I mentioned before in my prevention outlines, part of that will be related to prescription for pain post-surgery, and we need to include that as part of the prevention as well.
Okay, thank you. Mr. Eccles?
Thank you, Mr. Chair, and through you to Dr. Zayed. The one that caught my eye on there, the interesting, was correctional services had 17 or 18, and you go, yeah, we're in there in a very restricted, supposedly facility, and yet not only is it heavily used, as we know, but obviously to fatal portions that happen there. So I guess how much can we do on prevention or preventing individuals from stopping the the availability, it's such a three-pronged, four-pronged, multi-pronged approach here. As society, how do we get to the end of that when you've got a very controlled, structured spot like what I understand, because I've never been in prisons. I know, shocking. Don't look like that, Luke. But my understanding is it's very limited and whatnot, and yet here we have 17 deaths in Ontario by overdose in the facilities where you're not even supposed to be able to receive the drugs. And so it's a huge issue, and I guess I'm just struggling with it, from a police force, from a societal thing. How much of a battle are we losing here on this? Just a comment from my perspective.
Through you, Mr. Chair, I agree with your comment. And of course, I remember when I was a resident and we had a field visit to the prison in Kingston, and I was surprised really with the kind of things that people can do to get drugs or inject. So it's a big problem, and that's why a report like this is important, to have this public health approach or population health approach, not to focus on only one thing, but to have this multiple intervention in many places. So health unit will have corrective services. They really have a strategy, or try to have a strategy for intervention as well. So but it is a good report to inform policies and inform this intervention.
Yeah, Dr. Era.
Yeah, thank you, Mr. Chair. I'm just gonna step back and make a kind of a couple of remarks about the situation from a bigger picture point of view. There are many things that can be done in public health to tackle this issue, and I am very confident with Dr. Zayed's leadership of this file that we are doing everything we can and going over and beyond what is the mandate or the requirement is. And for the benefit of the board members who were not able to attend last time, I know there was conflicting schedules with other events. So we addressed the questions from the previous or the meeting from 2-3 meetings before about the situation in Grey Bruce and how it stands comparing to the province. And we had reduction of 50% of death from around 40 to 19 or 20 between 21 and 22. And that is quite significant. And if you compare where the health unit stands comparing to other health units across the province, we looked at different months from 22 and 21 and 2023. And the health unit is at the lowest number of deaths related to substance use comparing to the rest of the province, and of a magnitude of 40 or 50-fold. When Grey Bruce is within the lowest 5, and you look at the highest, probably Toronto, if my memory is right, and the difference in numbers is not a magnitude of a double or triple, it's 40-fold or so. Again, we'll be more than happy to bring this data or this update quarterly and not just monthly for the bigger data or the bigger picture. But all of this, I just want to tailor it to, I really said this before and I will repeat it. I thank Dr. Zayed for her work, and she's very humble. She just in her update mentioned that she's meeting with the president of Iceland and Dr. Tan, as if it is something that when a leader of a country visits another country and the top doctor in that country, and both of them request Dr. Zayed's input around that table. That's just us, tell all of us that how lucky we are to have Dr. Zayed around our table and leading our task force or workforce. I just want to end it there because, I've repeated this a couple of times, but people sometimes might, or our audience might think that he's saying this for the sake of saying it. No, but I do mean it when I say it. Thank you.
Thank you. Helen Claire.
Thank you through you, Mr. Chair. The opioids are ubiquitous in every area of life. Just in Canada, we saw on the data that the excellent Dr. Zayed presented, not just correctional facilities, but long-term home hospitals. We know they're in schools, they're everywhere. And as Dr. Zayed said, it requires a multi-prong approach where only public health, we can only do so much. In my opinion, until there is more done at the border, that's the single area that really, in my opinion, needs to step up to stop the easy flow, of course, of guns as well, but in this case of drugs across the border. It's only when it isn't so ubiquitous that we're going to be able to have a handle on this. So I just wanted to say that, and also to thank Dr. Zayed. We are indeed lucky to have her with her incredible, impressive credentials as part of Grey Bruce. Thank you, Mr. Chair.
Okay, thanks, Helen Claire. Okay, if there's nothing else there, then we will move on to the staff report to tobacco. Dr. Eric.
Thank you, Mr. Chair. The report is straightforward. The recommendation is to receive this report for knowledge, and it's related to commercial tobacco use rate in Grey Bruce. It has always been higher than the rest of the province and continues to be. We're standing around 16% Grey Bruce residents smoke daily compared to 9% in the province, and the data comes from the Canadian Tobacco and Nicotine Survey 2021. There are a number of things the Health Unit can do. Nevertheless, marketing of tobacco and is provincial and national sometimes, or global. And there are certain things the Health Unit can do, and we have been doing after the emergency. We're revitalizing certain aspects or interventions, whether it's a nicotine replacement therapy or all staff training model, or internal tobacco champion team and community practice. Just a number of interventions that our team has been working on and will continue to work on. And we connect with the TCAN, which is the Southwest Tobacco Control Area Network, and the province as well, the Ministry of Health and Public Health Ontario and other agencies. The recommendation, Mr. Chair, is to receive that.
Thank you, sir. Questions on that report? With a question on that, okay, I'll then look for a mover and seconder then to receive under 7 point.
Question.
Sorry, we do have a question? Sorry, Mr. Eccles?
Move to receive.
Move to
Oh,
receive.
he's moving and seconded by Luke Charbonneau. Any further discussion then regarding the MOH's report, those 3 segments? All vote and all in favor, that's carried. Now we're down to number 8, corporate services. Assuming coming into the room or okay. Yeah. Front center. Okay, go ahead. Sure.
Morning, everyone. So this is the March 2023 financial update.
So at the end of March, we were in a surplus position of just over $50,000. Our mandatory programs and our COVID programs are currently fully funded by our mandatory program funding. Our seniors dental program was in a small deficit. As some of the dentist fees and contract services that we have are over budget year to date, but we're closely monitoring those lines. We just want to fully utilize that budget this year. So we're in good shape for that program. March 31st is the year end for our Healthy Babies, Healthy Children program. So we fully spent that budget at year end. Our Children's Oral Health Initiative program also has a March 31st year end. We have a small surplus in that program, and the funding agreement for that specific program allows us to carry forward any unspent funds into the future fiscal years to utilize. So there's a plan to use that in the 2023-24 operating year. Year to date, our funding is below budget. We still have not received our funding announcement from the Ministry of Health where we requested a 2.5% increase. So we're waiting on confirmation from the ministry. They did say at a meeting in May that the earliest we could expect an announcement would be middle of June. Potentially the latest would be in August sometime. So there is a bit of a period there where we're going to have to wait to see what the funding announcement will be for the year. For expenses, we've had some gapping in leaves occur during the year. So our salaries and benefits are currently under budget by about $75,000. Building occupancy costs are in line with our budget, and our operating expenses this month for March were over budget by $28,000. Again, mostly with the senior dental program and the dentist fees that we're seeing. But year to date, on a consolidated basis, our expenses are $33,000 under budget. For the Walkerton dental clinic renovation, so the drawings for the space have been almost completely finalized. The next step is to hire a contractor to do the renovations for the space. We got a project timeline update this last week, and the project's moving according to the timelines, and they're expected to be completed by early March 2024.
Good news update all around. Questions from anyone? Mr. Craig.
Through you, Chair. As you go deeper into this process, one of the numbers that jumped out at me this time around, and thank you for the good work you do, by the way, was public education. And in the, we are public health, providing public health, and it, from Dr. Zayed's reports and Dr. Harris, it's, the more, Sue Carlton's, like, the more people know about stuff, the better informed they are. And public education in our budget is like minuscule. And so for my education, I can't help but think that the frontline workers are educating every day as they go. But could you tell me what our policy is or our direction is for those funds? Like I said, media releases and targeted things like that, or is it somehow ever built into the work component of the staff? I just need some clarity about how we direct public education from the board level.
Yeah,
Sure.
through you, Mr. Chair, I can speak a little bit about the budget of it. So there has been enhancements to the public education budget in the sense that we now have 2 communication coordinators as part of our team. So we previously had 1 kind of media person. We now have 2 that can focus on internal, external communication, newsletter, media releases, as well as our social media presence. So being a lot more engaged on Twitter, Facebook, and all those other platforms out there. So we've enhanced it. We've invested more in people, I guess, that can do kind of that education versus that public education line that you're seeing the operating expenses historically has been like radio releases and print media and stuff like that. So we're still doing some of that, but we're doing a lot more content creation in-house that we're able to circulate to our partners from an educational standpoint.
Dr. Zayed.
Yes, through you, Mr. Chair. Also adding to that we have the communication plan, and the communication plan is not only about that public education budget. It's really taking multiple audience. So, for example, I give an example of vaccine planning. So, vaccine planning is we meet every 3 weeks with communication and vaccine. and see how the vaccine is, like what is the vaccine coverage, what kind of message we want to convey, and through which route, even if it's, for example, for seniors, it goes to radio and goes to direct delivery of message, or through like brochures or things delivered to long-term care facilities. If it is for the public, again, it's not only through media release. We rely on media release in certain situations, so we have a policy for communication about certain things and how we are doing it through multiple audiences.
Here's your question. Okay. Other questions for Kim? Seeing none, take a mover then to receive the financial report. Moved by Kenneth Craig, second by Keith Carlton. Any further discussion regarding the financial report? All in favor? That's carried. Thanks, Kim. Now we're down to just the in-camera. Okay, so I have a motion by Sue Patterson, second by Luke Charbonneau, that Board of Health now go in camera to discuss 4 issues listed on our in-camera agenda. All in favor? Carried. Okay, back to regular session. So I'll declare that we only discussed the matters in camera that were presented on the agenda. Looking for a mover then to adjourn today's Board of Health meeting. Moved by Helen Claire, seconded by Gordon Peabody, that we adjourn the meeting. All in favor? That's carried.
All right.
Thanks, everyone, for your time today. And as I say, hopefully everyone has a good day. We'll look forward to next board meeting, which is June 23rd. Thanks,
Thanks,
everyone.
everyone. Bye.